So I would like to introduce our next speaker, Dr. Lim Yi Wen, who is a clinical specialist in our department, and she has a keen interest in cornea and hopefully a cornea fellow in near future. So today she will be presenting on the ophthalmic approach for Stevens-Johnson syndrome, which I'm sure all of you know is a life-threatening condition, but we have often realized that ocular involvement is often overlooked or referred late because during the acute phase, we do understand that attention has to be on patient's systemic condition. So hopefully this presentation today will highlight the importance of referring these patients early in the disease phase to us, because if not treated adequately, can lead to blindness. So over to you, Dr. Yi Wen.
All right. Thank you, Prof. Sujaya, for the very kind introduction. Thank you all for staying with me for this second topic, focusing on the challenges in managing the ocular complications of Stevens-Johnson syndrome in patients with co-existent autoimmune disease. So as far you know, Stevens-Johnson syndrome, which is also frequently known as SJS, is a very rare immune-mediated mucocutaneous disease characterized by extensive epidermal necrosis, exfoliation, and multi-system involvement. The pathogenesis itself remains incompletely understood, but now is commonly attributed to idiosyncratic immune reactions triggered by systemic medications or infections. Several comorbidities such as type 2 diabetes, peripheral vascular disease, malignancy, psoriasis, prior drug hypersensitivity, and systemic autoimmune diseases have been identified as potential risk factors for the development of SJS. Ocular involvement occurs very frequently in the course of the disease, being divided into acute and chronic phases. And the chronic ocular complications of SJS are likely multifactorial rather than a direct extension of the acute phase. And it features immune dysregulation, fibrosis, and persistent inflammation. Persistent inflammation in chronic phase can lead to a range of debilitating sequelae, including keratoconjunctivitis sicca. In ophthalmology field, we used to have very fancy kind of name, but it simply just means dry eye in this case. And corneal neovascularization, as shown in the uppermost picture here, what you can say is just the development of new vessels. All these new vessels, which is not supposed to be there in a transparent cornea that you used to see, and causing the cornea to be opaque at this station. Synfibrotic formation, as you see in the second bottommost picture, the attachment that is due to fibrosis and persistent inflammation and causing palpable conjunctiva to stick to the corneal surface itself. Trichisis, entropion, and ocular surface keratinization, which is very common. So in acute phase, the most common ophthalmic complaints being complained by patients if they are not intubated mostly are because of visual disturbance, glaring, as well as eye pain. And often when we have a look in the eye, these are the things that we can pick up in the situation in acute phase. From here in the picture A that you can see, the black arrow shows some kind of changes over the lid margin, whitish base, which is actually known as lid margin necrosis here. And you will see the white arrow here showing conjunctiva swelling, which is often known as conjunctiva chemosis in this case. And the eye appears to be slightly injected. Second case is the much more common presentation that you may pick up, the pseudomembrane development over the palpebral conch and causing the eyelid to be wet and a lot of discharge coming out from the surface. So these are the commonest pickup that we used to see in acute phase of ocular SJS. Even though we are not going to deal inside too detailed in chronic phase, these are some of the picture I may want to show you because these are all those preventable debilitating ocular sequelae if we were to intervene early, timely. So from this picture, you can see synfibrotic keratinization over the palpebral conch and very bad conjunctivalization and causing opaque cornea, as well as neovascularization that I mentioned on earlier. The vessels grow at the surface. And here you see entropion, very bad corneal keratinization in this eye, which caused blindness in this patient. And chronic phase used to occur in 35 to 90% of SJS that you see. So this flow diagram here, outlining the protocol for stepwise management as well as the grading system of ocular SJS, ranging from grade 0, simply means that there is no ocular involvement, and grade 3 with a very bad corneal conjunctiva or eyelid margin involvement with pseudomembrane formation. If you to look across in this diagram itself, the treatment per se are almost the same, from the topical antibiotic used to cover for secondary possible superimposed bacterial infection, and topical steroid, which is the mainstay of treatment to deal with ocular inflammation, and you may need some kind of steroid ointment for the surface as well as the eyelid involvement and artificial tears. The only difference here that we may want to highlight will be the use or timely intervention with amniotic membrane transplantation, which is a very good option with evidence-based discussion later. So here come the question, when should ophthalmology referral be made? The answer for this would be as soon as possible, as fast as you detect a case of ocular SJS. Right, we would like to share with you a case that we recently encountered in ICU, in which the patient was a 74-year-old lady being referred to us after developing SJS secondary to vancomycin at day 2. So what we can see from the initial presentation here, there is only minimal conjunctival hyperemia, which is the injection of the conj, and we actually diagnosed the patient having grade 1 ocular SJS. And if you can recall the protocol diagram just now, we started the patient on very mild topical steroid to cover for ocular surface inflammation. However, a week later, with the disease progress from SJS to TEN, the toxic epidermal necrosis, patient developed very bad escoriation over the eyelid, both upper and lower, from the right and the left eye. And what you can pick up here is the cornea staining by the fluorescence here. So there is conjunctiva, cornea, as well as lid involvement. But good thing is there is very minimal pseudomembrane at this stage. But anyway, this is what we call the patient has got all the criteria points towards grade 3 ocular SJS. And because she is already under our follow-up and we pick up quite early at this point, a week later, so we decided to go on with amniotic membrane transplant for this patient. So amniotic membrane transplant used to have several methods for the preparation itself, whether with suture or sutureless. In this case, the patient is quite, I would say, a bit sensitive. Whenever you want to examine the eye, cause a lot of pain to her. That's why we thought to go on with sutureless amniotic membrane transplant along the bedside in ICU setting. So what we'll need to do is to stick this amniotic membrane to cover up all the raw surface that you see, spreading into the lid, the cornea, as well as the conch area. So this is the exact picture that we took after the amniotic membrane being glued over the lid margin. And you see it sits nicely on the raw surface and keep dry at that point. So a day, 2 days after that, you will see slowly improvement in terms of the eyelid escoriation. There's no longer progression and the eye become even more quiet with topical steroid as well as antibiotic close-up. 9 days post-posterior, you see nicely the lid margin. There's no escoriation noted. There's no conjunctival chemosis, no more swelling, and the epidefect over the cornea is slowly improving. This is her 2 weeks post-procedure. You see total resolution over the right eye epidefect. Very minimal exposure here. The epidefect persists over the left eye is mainly due to exposure keratopathy that the patient has. But nevertheless, we are quite amazed with the outcome from this sutureless amniotic membrane, whereby the lid escoriation, the conjunctiva, and palpebral conch are so well healed after the treatment. So despite growing awareness of ocular involvement in SJS, the clinical progression and management of ocular complication remain highly variable and poorly understood. So the presence of underlying autoimmune diseases add another layer of complexity. And here we are going to present to you, to walk you through 2 cases that we have where the patient has got co-existent autoimmune disease and on top of that, diagnosed of having ocular SJS post-treatment. So a very, very lengthy slide, but we are going to just highlight to you the important point from this case. This is a 55-year-old Chinese gentleman here having underlying diffuse membranous glomerulonephritis was developed SJS after allopurinol use. There is ocular involvement at that point and requiring amniotic membrane transplant ×2 for the lid margin and corneal epithelial defect. And in March 2021, there is a relapse of ocular inflammation, and that that particular relapse has got very minimal clinical response towards multiple immunosuppressive that we have tried on for this patient. He was then finally commenced on oral mycophenolate mofetil, 1 gram twice a day, and was given 2 doses of 1 gram of intravenous rituximab. The combination of this therapeutic treatment successfully controlled the inflammation and stabilized the ocular surface. This is what he had during the second relapse in March 2021, whereby I started to have epithelial defect over the right eye, and the left eye has got very bad corneal vascularization as well as corneal opacity due to ocular surface failure. And with rituximab and also MMF, you see, this is the amazing treatment outcome that we actually see in this patient. The right eye completely healed, there is no more epi defect, and is seeing good with 6/6 vision. And the left eye, having said so, the vascularization is there, but the opacity seems to get less dense in this eye. And with sclera contact lens that he used to be wearing now, his vision can best get to 6/24, and he's still functioning with this eye. Another case that we have, a 34-year-old very young lady with rheumatoid arthritis. She developed SGS in August 2021 with ocular involvement, which initially resolved with topical steroid. Sadly to say, he had relapse of ocular surface inflammation in September 2022, and prior to that, he developed corneal perforation. So again, this patient has got a few more procedures done for the ocular surface keratinization. A lid margin mucous membrane graft was done, and of that, 2 episodes of relapse of ocular surface inflammation were observed post-op. And she also required an intravenous rituximab of 1 gram, given twice 2 weeks apart, with MMF to get the disease control in terms of systematically and ocular per se. And at the end of the session, at the end of the day, MMF has to be switched to baricitinib in her due to the flare-up and systemic symptoms that they have in her uncontrolled rheumatoid arthritis treatment. So this is her being referred to as there is this ocular opacity which the cornea perforated the last time in September 2021, and all this shows that the corneal epidefect that she had due to the relapse ocular surface inflammation. And post-treatment, you will see the eye is much more quiescent now. You see the keratinization over the conch has been one of the chronic signs of ocular sequelae in SGS. But the ocular surface scar has been there, and there is no more vascularization seen growing across the cornea, leaving her a good, or I would say an adequate vision for daily function. All right. These are a very lengthy page on clinical take-home messages that we have. SGS can evolve into chronic autoimmune ocular surface disease, whereby sometimes biopsy is valuable. And of all this, if you couldn't remember a single main point, I would just say the main point that you want to take out from this session itself is to refer to us, the ophthalmologist, as early as you can when you pick up a case of SGS under your care. All right, so the conclusion for today's session, SGS is a very rare multi-system disease with severe ocular surface sequelae, which can lead to bilateral blindness, and careful examination and adequate, timely, aggressive ophthalmic management in the acute phase are essential to prevent or moderate chronic SGS. And bear in mind, restoration of the ocular surface in SGS and TEN remains challenging, and it showed up in the last 2 cases that we showed you. And with every single procedure being made, there will be a chance of relapse of ocular inflammation, which means systemic immodulation is rather important. And here brings into the need of multidisciplinary care in this kind of cases. We appreciate rheumatology, dermatology, and especially anesthesiology to help us to improve the patient outcome in treating ocular SGS. All right, these are the list of references that we have. Feel free to drop a message if you do have any question. With that, I thank you.
Thank you, Dr. Ewen. That was a wonderful and a very visually pleasing presentation. And thanks for collecting all these pictures for the presentation so that the understanding is much better, as we do understand that ophthalmology can sometimes be a bit confusing. So these cases, as we have highlighted, were managed in our center, and so far they are stable and doing well. And it highlights that if we are involved early in the management of these patients, they have good outcomes. So with this, I would like to end the session on our part, and we are happy to take any questions if there are any.
Yeah. I saw a question from the Q&A box. Thank you, Prof. Tengku Sarama, on your question. Yes, the amniotic membrane will drop off after a while, but in the case of acute inflammation, whereby the inflammation is so intense, sometimes it fall off. It even fall off, or what we call it will kind of like disappear even earlier. So the time frame being offered in amniotic membrane usually is about 2 weeks to 6 weeks time. Therefore, despite putting on the patient with amniotic membrane transplant, adequate immunosuppression in this case is rather important to make sure that the amniotic membrane stay longer in the eye to give enough or adequate protection on the lid. All right, the next question on should all SGS patients be referred even before we see eye involvement? Yes. I think this is the main point that we want to bring up from this discussion. I will say, please refer all SGS patients to us because like you see in the case that we shared, the patient kind of like progress into from grade 1 to grade 3 ocular SGS in a very short time period in a week time, whereby if let's say we were to involve early, we possible can kind of like moderate the development or progression of ocular SGS involvement, as well as to actually bring up some sort of timely intervention for the patient itself to prevent further debilitating sequelae in this session. I hope I answer your question. If there is any other question, we will happy to take it now since we do have some minutes left behind. How does the perforation heal? All right, we got another question here. How does the perforation heal? So mainly because like I initially talked, I think during the talk itself, we put down there in the requirement of chronic sequelae in SJS. It often features immune system dysregulation as well as fibrosis formation. So usually the perforation will heal initially by the means of us getting the so-called perforation stabilized. But with fibrosis, with keratinization, or even conjunctivalization that happen after the acute event of inflammation, the cornea itself will seal up nicely. But of course, in the acute setting, we have to do something to seal up the hole and hold the perforation across with them. Yeah, so the main thing is still the control of inflammation, which is the mainstay of the treatment, and make sure the eye is tectonically stable at the acute setting before allowing sometimes for the perforation to seal up with keratinization or even scarring formation.
So I'd just like to add that these perforations will heal spontaneously if we have given adequate additional treatment in terms of either applying corneal glue, which we had done for the first patient, or using amniotic membrane, or sometimes even a small patch graft, or a corneal transplant. So this is how the inflammation will, the perforation will heal, but the key point to take home is that if the inflammation persists, any procedure we take will not be successful in such patients.
There's another question on, is there an established ocular screening protocols in Malaysia or UMMC following exposure to certain high-risk drugs, allopurinol before SJS fully manifests? Of yet to date, we are not aware about any ocular screening protocols, especially in UMMC itself. That's why that we think that this topic will be much more of eye-opening to everybody, to every single other team, to refer to us as early as we can if you encounter one.
And also because these cases are not so common and extremely rare. So I think probably that is also one of the reasons we do not have a screening protocol. But evidence does show involvement of, genetic predisposition to SJS. So maybe in cases that we are really concerned, we can explore this in future to do a genetic testing before we expose these patients to at least allopurinol, because that is well documented in literature. Unfortunately, antibiotics and all is not being documented. So these are just risk factors, and we need to keep an open mind when patients present with these kind of lesions with a history of ingestion of these drugs or viral infection or even Mycoplasma pneumoniae.
All right, there's another question in the chat group. What are the other indications of amniotic membrane in eye diseases, and why are they so effective for surface conditions such as this case? All right, I think amniotic membrane, probably not everyone is familiar with that. So amniotic membrane is actually quite useful in terms of ophthalmology field. Basically, it can be used for some kind of tectonic purpose, like in this case, we close up some kind of holes. And the second thing is to protect the raw surface that we used to show in the first case. So basically, they are inflammatory. They can bring down or control the ocular surface, and they can also act as a barrier, I would say, in terms of raw surface, for the raw surface to heal and to prevent further keratinization or rubbing onto the corneal surface in that case. And also at times it has some kind of antibacterial kind of property whereby it can actually reduce the possibility of getting bacterial infection. And main thing that this amniotic membrane is to be used in cases of such of ocular SJS is mainly for its anti-inflammatory effect, and whereby we introduce as early as grade 2 to grade 3 ocular SJS that we encounter, so that we can reduce the ocular surface inflammation on top of the topical steroid as well as the systemic immunosuppressant on board.
So just a quick correction. And amniotic membranes are not antibacterial. Please don't take that back home. They act as a biological bandage, I would say, and they are anti-inflammatory, and they help to reduce the inflammation. At the same time, they are providing support. So the question here asked is, what are the other indications? We can use it for any cases of when there is a surface de-epithelialization in patients with ocular surface diseases, or there is progressive corneal thinning, or there are even a lot of indications of usage of amniotic membrane in oculoplastic clinics, which is basically when they work on the eyelids. And that, I think my colleague will be able to inform better. So there are multiple indications of amniotic membrane in ophthalmic use.
Has the amniotic membrane been processed and packed, or is direct from labor room? So the amniotic membrane that we use is already processed and packed in the solution before sent to us. It's not directly from the labor room, because it has to go through some kind of process of so-called antiseptic, and also to keep in the sterile solution, the preservative glycerin, to send to us. And so far, I think in our setting, we do not have a lab to process it ourselves. That's why we have to actually get it from outsource. Yeah. All right. I think it's time. Now it's already 9. Thank you everybody for all this burning question that we had, and very active kind of interaction that we have for this session. If there's no more question here, I think I'll thank you for this session and hope to see you guys again the next round. Thank you.